I'm Lakshmi, um, parent of Nishant Kalavakalanu, um, taking us back to about 2018 Labor Day weekend. We had gone to Colorado Springs to celebrate our son's achievements at the US Air Force Academy. We looked up and saw a glider soaring across the sky, and it is something that he was doing at that time. And he would soon be training the next class of cadets. Our hearts swelled with pride. 2 days later, after a weekend of joy and celebration, he said he was feeling tired and wanted to take a nap. He woke up again 12 weeks later. 7.5 years later, we still live in the aftermath of Norse fires. We didn't know what the prognosis was then. Nishant was struck with this as a 19-year-old on active duty and now fights as a retired veteran. Even now, there are lonely, frustrating, disorienting days for him and for us. The loss of a loved one or the life that we once knew is the common thread that binds many of us here together. Whether it's the grief of what we were before or the person we have become after, Norse reshapes not only the patient but the entire family. We were staying across from the ER, and so we got him into the observation within minutes. Every test, lumbar puncture included, came back negative. And yet he was seizing almost hourly. Despite the seizures, because his vitals were stable, he could not be admitted into the ICU. So we moved to a second hospital. And in the second hospital, in the ICU, his seizures escalated and he was put into an induced coma. Our ER doctor friend told us, think of it as rebooting a computer. A few days later, things should normalize. But twice they tried to reduce sedation, and twice he seized violently. IVIG and plasmapheresis were attempted. Eventually, he was airlifted to a third hospital. ICUs aren't designed for months of care. Treatment was supposed to be seamless in spite of weekly physician rotations, but that was not the reality. Each week brought a new neurologist with a different treatment plan. One raised his phenobarbital, another thought it was too much and lowered it. We spent almost 24/7 watching our son, keeping track of the changes in medication and symptoms, listening to the patient's families of utmost importance, and planning the treatment and changes with the family might help the neurologists also. One Sunday night, they halted the coma medication based on a phenobarb level of 14. 17 hours of seizures followed. We escalated our concern to the director of the ICU, who brought in a Norse specialist, a pediatric neurologist, to consult on the case. He became the single consistent voice and started anakinra, raising it to 6 doses a day. Slowly there was progress. Just as hope returned, Nishant's gut shut down. 90% of his small intestine died due to lack of oxygen. The Air Force was told to prepare for the worst, but the ICU doctors, residents, and surgeons didn't give up. Against all odds, they found a cocktail of medications that brought him back. Nishant would not be here if it was not for the care of the ICU nurses, the assistants, the therapists, so many people that took care. We later heard that the EEG techs were cheering the day he tried to rip off his EEG leads. It was a sign that he was waking up. Rehab meant relearning to walk, talk, and think while tapering a high dose of phenobarbital, which was more than even blood tests could measure. We joked about betting on the daily drug levels. Sometimes humor is the only anesthesia that a family can get. Today, Nishant attempts to live independently, managing long-term effects of short bowel syndrome, cognitive hurdles, side effects of medication, and frequent seizures. He takes 1 or 2 classes at UT Austin. That in itself is a miracle. 7 years later, his prognosis is still unknown. If I can leave you with anything, it's this. Norse fires is brutal, mysterious, and under-researched. No family should have to beg for consistent care. No patient should be passed from one shifting protocol to another. We need research, we need awareness, and we need compassion that lasts longer than a hospital rotation. Thank you for listening.
Thank you for having me and allowing me to share my experience. My son David was diagnosed with fires in 2017. He is now 8.5 years post-onset. During the acute phase, we actually had what I consider a very good experience, remarkably so, considering it was the worst time of our lives. David was admitted to Nicholas Children's Hospital in Miami. There, we were fortunate to meet a particular nurse we could request on her shifts. We requested her because every time she came into the room, she took the time to explain exactly what medication she was administering, what class it was in, why David needed it, the dosage, and when the next dose was due. When she was on duty, we didn't feel like bystanders. We felt like participants in David's care, even when we couldn't do anything physically to help him. Although many neurologists came and went in the PICU, there was one neurologist we knew David belonged to. She oversaw his care. If there was a question about next steps, our first thought was, what does Dr. Hislop think about this? That clarity, knowing who was responsible, set our experience apart. We knew who to turn to, and that gave us a sense of stability in the chaos. There was one moment I'll never forget. David's neurologist burst into tears while speaking to us about how much she wanted David to succeed. Some might consider this behavior unprofessional, but it gave us hope. It showed us David wasn't just a case, he was a little boy whose life mattered to her. Doctors, I implore you, please don't be afraid to show your humanity. Your compassion might be the very thing that gives a family the strength to keep going. It might be the bridge that builds your trust in the care you're providing. That trust, however, becomes harder to maintain in the chronic phase of the syndrome. David is now 8.5 years out. Our focus today is on balancing seizure control with his quality of life. And that balance is not theoretical. It's daily, practical, and very real. If a medication controls his seizures but sends my son into mania or violent rages, it's off the table. That's our line. We once tried a medication that became problematic every time we exceeded 1.5 mLs BID. David became violent. I documented the increases, the behavioral changes, and even pointed out that the same reaction had occurred during a prior trial of the same drug. When I told the neurologist it wasn't working, he said, "That's not a commonly listed side effect. We can refer him to psych if you like." For months, I was dismissed even as I was being attacked by my growing teenage son, even with detailed logs, even with a clear pattern. Finally, I insisted we return to 1.5 mLs BID, and of course, the violent episodes stopped. Another time, with a different neurologist, David was having silent seizures at night, not moving at all, quietly seizing and desatting until he turned blue. My husband and I took shifts, staying up at night just to make sure he made it through. We begged his neurologist for a medical-grade pulse oximeter. "That's not standard practice," he said. Thankfully, David's pediatrician had the heart to write the prescription. These are just two of many occasions I was treated as if I brought no value to the table. I want to highlight those specific phrases, not a commonly listed side effect, and not standard practice. Because here's the truth. There is no true standard in the chronic phase of Norse or fires. Yes, chronic epilepsy is common, but no epileptologist can predict which medications or interventions will work for a given individual. Each patient is different. Treatment must reflect that. Treatment must be individualized. I've become an expert in my son's particular brand of fires, and I say that with confidence. I track seizure trends, I log medication changes, side effects, withdrawal timelines, and behavioral shifts. David's life has been saved countless times because I insisted that my observations were real, despite them initially being dismissed as behavioral health issues or signs of disease progression. In fact, these were symptoms of markedly elevated ammonia levels related to anticonvulsant titration, interactions between concurrent anticonvulsants, and other adverse medication effects. In the chronic phase of David's case, he is the subject, I am the lead researcher, and the majority of the data needed to treat him lives with me. A neurologist cannot create a successful treatment plan without understanding that. Dismissing me means dismissing the largest, most complete data set available. No good doctor wants to make decisions using insufficient data. Thankfully, with relentless advocacy, we've been able to individualize David's care. But progress has rarely come from the system. It has come from me continually researching peer-reviewed studies, presenting them, and pushing for action. In a perfect world, his doctors would bring the research to me, saying, look at the possibilities, instead of, that's not standard, or that side effect isn't on the list. But since we don't live in a perfect world, I'm taking steps to create one for him, and that begins here. To the doctors and professionals in this room, please don't treat families like secondary participants in their loved one's care. We are not just caregivers. We are data collectors, observers, advocates, and often the difference between a treatment plan that works and one that fails. Trust us, listen to us, collaborate with us, because in this rare, unpredictable condition, partnership isn't optional, it's essential. Thank you.
Thank you. Thank you, Desirae, for sharing your experience, and thank you everyone for giving us the opportunity to share ours today. My name is Janie Yang, and I'm here with my husband, Ranjan Roy, and we're parents of Samaya June Roy Yang, our beloved daughter who passed away 1 month shy of her 7th birthday on November 18th, 2023 from fires. Just to give you a little bit of background, everything happened very quickly. It really just began with a simple fever that occurred on November 10th. And by the evening of November 14th, we were rushing her to the ER at NYU Langone Children's Hospital, located in Manhattan, where we live. Just as I was in the ambulance with her, and just as we were approaching the hospital entrance, that's when she had her first seizure, and it just never stopped. We didn't know what was going on, and despite the incredible efforts of the ICU team, Samaya passed away shortly after, like 4 days later. And so, to be quite honest, that entire week was a complete blur. We were overwhelmed by the unknown, what's happening to her. We didn't know what was causing the seizures. We were confused by everything that was happening within the ICU. But during the entire experience, there were 2 things that really stood out to us during those days. And I think it's really consistent from what Lakshmi has shared with you all, just in terms of the consistency of communication from the medical team with each other and with us. And also just drawing from what Desirae just mentioned, just in terms of the partnership, how important that is, and how empathy, how it comes through, and really just acknowledging our observations as parents rather than dismissing the noticings that we had, because we were in the room with her 24/7 during those moments. And so I'm going to pass it on to Ranjan right now. He's going to go ahead and just focus on those 2 points, just the communication, the importance of the communication, the consistency communication amongst the medical team, and then also how empathy, how important that piece is during the entire process.
Yes, so I'm Ranjan, father of Samaya. I think, again, overall, there was a lot of doctors, a lot of nurses who really made the experience comforting at times. But I know that the goal of today is to try to kind of walk through where there could be areas of improvement and kind of breaking down what Janie had said. So first, on communication, there's 2 parts of it to me that stand out. One, at NYU, and recognizing at a larger institution, the good and bad is you have experts across the board, but the bad, not having a single point of contact, even trying to learn what an eleptologist, rheumatologist, nephrologist is all overwhelming, was all overwhelming for us. Um, Being in the worst situation and trying to process concepts and being very transparent. The two most trusted sources of information for me during this time were text threads with friends who are doctors and trying to have them translate things, and using ChatGPT at the time to try to ask questions. What is the central venous catheter? These kind of things. It's all new, especially the unique part of Norse and Fires is it's typically presenting in someone who has not had epilepsy in the past. So everything is new. And that single point of contact, I think it seems echoed across. I don't know who that is and how that works, but that's one big area. How do you communicate a rare disease when it's a suspicion? This was, we had a neurologist early on ask, have you heard of fires? We suspect it might be fires. We had a nurse during the night shift when we brought up fires say, don't Google fires, which of course I did. And then there's an autocomplete that showed mortality rates up to 30%. So again, trying to like discover this, and the information out there is terrifying and not promising. Um, and then slowly it entered the conversation. And I think, Doc, earlier you were there's something around like there's like having a more clear checklist of how do you get to fires, noting that a diagnosis of exclusion is very difficult to get to because it's not a straightforward diagnosis. Maybe with cytokine readings, it could be more straightforward, but recognizing it's an incredibly complex thing of when and how it is communicated as a suspicion, but coming up with a clear playbook on this, I think is very important. What Janie alluded to in terms of trusting the parents more, this was a tough one. We saw her foot twitching, brought it up, were dismissed. The EEG monitors, recognizing the complexity around this, as we just stared at those, we're told not to stare at those, but of course it's there. You see activity, you try to bring it up. And again, after the fact, recognizing that it's not going to change anything if you see a little activity for the most part, but still how to deal with those kind of signs that are present to parents, I think is incredibly important. And then on the second main area around empathy and stress, and I'm sure this is typical in lots of any PQ situation, but those early decisions, asking parents for to give permission for things that they have no idea what's going on or what is happening. I'm not sure how to improve that, but I mean, one of the most awful moments that lives with me. Samaya had blue lined, her heart had stopped. We were basically like sitting on the ground, and then they put her on ECMO. And the decision was, we were trying to ask, can someone please just refer us to, well, can you bring in one of the other doctors? And we were told, we don't have time to get cute. We need a decision right now. And recognizing there's an urgency in some of these moments, but bringing more explanation, empathy, or I mean, it's something that I think the more structure there is around this, it could be an area of improvement. And again, that on the topic of empathy, there's so many different doctors and shifts, and it kind of touches back on the single point of contact. And towards the end, encountering some doctors who, when we were asking questions, were very outright dismissed and even were defending themselves and like saying, I have 27 years of experience. Like these moments, it's tough because there's a lot of good. It's very easy to remember the bad, especially in our situation, and trying to control that across so many people, recognize it's difficult. But again, knowing the multidisciplinary nature of this will bring in a lot of people, but that single point of contact, bringing parents to either feedback in or coming up with much clearer ways of explaining, don't look at the EEG monitor because it's not going to affect any near-term decision because of ABC. I think the better these things can be outlined, just the more tolerable at best. obviously in an awful situation it could become. Thank you.